So hi everyone, welcome and thank you for joining. My name is Liz Farrow. I'm a member of the Dine and Learn Committee and I'll be facilitating tonight. Please note that this event will be recorded, so this means that your name and camera may be seen on the recording. The recording will be made available to members and posted on our, members only section of the website along with the slides after the event. Please make sure your microphones are muted for the duration of the presentation. I'd next like to acknowledge that I am grateful to live, work, and play on the unceded territories of the Musqueam, the Squamish, and the Tsleil-Waututh First Nations. And I would like to thank our division staff for making events like this possible and for all of their hard work. And you guys for coming. So it's a bit unusual for us to have two Dine and Learns within the same month in such short succession, having just had our informative ADHD presentation about 2 weeks ago. So we appreciate that you're all here and taking your time to participate in our Dine and Learn events. For tonight, funded division members in attendance will be sent an Uber Eats voucher valued at $60 within 2 to 3 business days after the end of the event. There will also be an evaluation poll. So at the end of the presentation, there'll be a QR code on Dr. Hahn's slide as well as a link posted in the chat. Please do complete the evaluation. It only takes 1 or 2 minutes and it really helps guide our future events. So tonight we'll be hearing from Dr. Jessica Hahn. Dr. Hahn completed the BCCSU Clinical Addiction Medicine Fellowship in 2019 and FRCPC Emergency Medicine Training at the University of Alberta in 2020. She currently lives and practices in Vancouver, splitting her time between emergency medicine at VGH and addiction medicine with the St. Paul's Hospital Group. She is the physician lead for virtual care under Providence Healthcare's substance use program, which encompasses Access Central and the Lighthouse Virtual Substance Use Clinic. We ask that you please hold your questions to the end. There will be time after the presentation is complete. There'll be time to unmute and ask your questions if you choose. Please also feel free to type your questions in the chat as the event goes on, and I'll make sure that we get to those questions at the end of the presentation. And I will now turn it over to Dr. Hahn.
Thank you so much, Liz, for the introduction and nice to meet everybody. Thank you so much for having me today. I'm very grateful for the opportunity to present to you about Access Central. So I'll be going over updates, improvements, and what you can expect as a community healthcare provider. As Liz said, please hold all of your questions or there will be time for questions at the end, but you can type them in the chat as the presentation goes along, but I won't be addressing any of the questions until the end. Access Central is a puzzle that fits together, so it's best if we address any questions at the end once you see how the pieces are aligned. So I have no actual or potential conflicts of interest to disclose. So what we'll cover, so we'll go over what's changed at Access Central in our workflow and why, an overview of the 3 Vancouver Coastal Health detox sites, how patients undergo triage for detox, what that means for primary care providers and community, and as I mentioned, a Q&A at the end. So first of all, what is Access Central? It is a patient-facing phone line for centralized triage for Vancouver Coastal Health-based withdrawal management beds, or colloquially known as detox beds. The phone lines are open from 9 a.m. to 7:45 p.m., 7 days a week, including stat holidays. And this centralized intake coordinates access to withdrawal management beds across the 3 VCH sites. So that's the St. Paul's Hospital Road to Recovery, Vancouver Detox Center, and Vancouver South Withdrawal Management. The phone number is displayed at the bottom of the slide. So in September 2023, Access Central underwent a significant overhaul with the goal to improve bed flow occupancy and have more equitable access to withdrawal management beds in our community. So the former state was a first come, first serve approach, kind of like calling and making a restaurant reservation. There was no mandatory specialized addiction medicine assessment, no case management, no virtual prescribing, and patients were just given access to the next available bed. So in our newer state, which I'll go into more detail, there's a mandatory specialist addiction medicine nursing assessment. There's now an Access Central physician on site 7 days per week. And we use a triage approach to the bed booking and then case management as indicated. So more about our new state. So there is a mandatory specialized addiction medicine nursing assessment. Most of the nurses that work at Access Central actively work in the substance use community in other capacities, such as working in detox, or they have previously worked in detox, and they're quite experienced with substance use care. The triage approach specifically focuses on morbidity and mortality factors related to patient substance use management. We'll talk in detail about our triage framework later in the presentation. We do some case management when that's indicated, which I'll also just describe more. And the Access Central physician, who's available on site 7 days a week, reviews nurse triage and site selection for detox whenever indicated. We operate the Access Central physician consult line, which I'll discuss, and then we offer virtual OAT prescribing through the physician as well. So this is just a slide to give an overview of how the overhaul has affected our wait times. So this is spanning the graph is spanning about it begins at 6 months after we implemented the change and goes up to about close to 18 months after that. So you'll notice that the biggest difference is with the dark blue line, that's our routine wait list. And so, at 6 months after implementation, the routine wait time was hovering close to 1 month. And in more recent state, it's down to less than a week. So that's where our most significant change has been impacted. And I'll talk more about the wait times in a little bit. So next, we're going to go over the basics, the basic framework of the three different detox sites so that you can know what your patient might expect at each of these sites and why patients might be allocated to one site versus the other based on their individual needs. So the first site we'll talk about is the St. Paul's Hospital Road to Recovery, or R2R. So this is 25 beds spread out over 2 units, both currently located at the St. Paul's Hospital on Burrard Street, but we'll be moving to the new St. Paul's Hospital next year. It has 24/7 nursing care, and several of the unique capabilities include access to IV medications and more frequent offering of PRNs due to lower nursing ratios. There's on-site labs and imaging, on-site security, access to specialist psychiatric, neurology, or ID consultation when indicated, complex wound care, dietitian consults, etc. So it is a collaborative hospital-based environment, although it is located in the outpatient building of the hospital and not the inpatient building. So Road to Recovery does pre-booked intake 7 days per week, and standby beds do get released each day if there are patients that haven't shown up for their booking. Notably, this is the site that has the most restrictive smoking rules. So there's only 4 supervised smoking breaks per day, which can be a barrier for some clients with high nicotine requirements. And it is currently our only site that has on-site Indigenous cultural supports. That's something that the health authority is working to implement at our other sites as well. But in current state, this is the only site that offers ICS. So common misconceptions about Road to Recovery is that patients do not necessarily need to be pursuing bed-based treatment or other aftercare recovery admissions in order to be eligible to go to the Road to Recovery detox. Road to Recovery itself is also the name of the greater coordination of care that our province is undergoing with regards to access to substance use care. It just happens to be also the name of the detox site, which can be a little bit confusing. So a patient does not necessarily need to be on a coordinated pathway in their substance use journey to go to the Road to Recovery detox site. So I personally think it should have been given a separate name because it has caused a lot of confusion. But it is the beds of Road to Recovery are allocated with the same, patients of a variety of different goals, just like the other 2 sites. So the next site we'll talk about is Vancouver Detox Center. This is 24 beds, also with 24/7 nursing care, also with pre-booked intake 7 days per week and release of standby beds daily. However, it does not have any access to IV medications, on-site lab or imaging, on-site security. There's minimal resuscitation equipment and no reduced availability of allied healthcare services and no other specialized medical consultation services such as psychiatry, etc. The smoking is better tolerated for patients just as there's a garden where they have relatively unlimited smoking access. But as I mentioned earlier, there's no Indigenous cultural supports currently. Vancouver South Withdrawal Management opened in March 2024. So this is our newest site currently. It's on the campus of George Pearson Center in South Vancouver at Cambie and West 57th. It's 18 beds, 24/7 nursing care, similarly pre-booked intake 7 days a week with standbys. And similar to Vancouver Detox Center, it does not have access to IV medications, on-site labs or imaging, on-site security, and it has minimal resuscitation equipment. It also has a patient guarding with relatively unlimited smoking access and also no Indigenous cultural support. So a fairly parallel site to Vancouver Detox Center, just in a different neighborhood. So next, we're going to move into discussing our detox triage priority criteria. This is an overview of the framework. We'll talk about each section in detail, so don't worry about being overwhelmed by this bird's eye view. But essentially, patients, when they call in to book detox, are triaged into one of three different categories: urgent, high, or routine. And that helps determine when they'll have access to a bed. So urgent is a target admission same day or within 24 hours. High category is target within 72 hours or 3 days. And then routine is anybody who doesn't fall into urgent or high categories. And then the routine wait lists fluctuate based on demand and bed availability. So that's where the most variable intake times end up being, is in the routine category. So first we'll go over the urgent category. So these are patients we try to get into a bed same day if at all possible. So these are patients that meet any of the following criteria. So the client will likely require a hospital admission if they're unable to access a bed. So we try to avoid patients being admitted to acute care, such as under internal medicine, for the primary purpose of withdrawal management if there is a detox bed available. It might be a patient who's presented to emergency department or a clinic. They've called Access Central, who are actively in withdrawal, who cannot be safely managed as an outpatient and are determined to have high risk of complicated withdrawal, and who are also deemed safe for transport to a withdrawal management facility rather than to the emergency department for their medical assessment, for example. Patients under the age of 25 or youth patients are in this category, as well as perinatal persons and their partners. We also add in patients who are not easily contactable, i.e., they might not have a phone or they might be unconnected to care and have shown that repeat connection attempts have not been successful. This is patients who are not easily contactable compared to other patients who are on the wait list. So not compared to an average Vancouverite, but who are less easily contactable than other patients who are waiting to get into withdrawal management, just as we have seen over time that there are some patients who we have a lot of difficulty getting into withdrawal management beds that are booked further out due to the lack of able to get a hold of them. The next is the high category. So these are patients with increased risk factors related to their substance use, again, focusing on morbidity and mortality consequences. So this might be, for example, severity of their substance use disorder, increasing hospital or emergency department contacts, frequency of opioid overdoses. The more recent, the more pertinent. It might be patients with repeated unsuccessful attempts at outpatient stabilization. For example, patients who are repeatedly started on low dose OAT or opiate agonist therapy, who have difficulty getting to pharmacy regularly, difficulty titrating, and are kind of not able to progress on their substance use plan as an outpatient, and an inpatient admission might help stabilize them. It's patients that might have a concurrent mental health disorder that's deemed to be decompensating related to their substance use. The most common one in this category would be psychosis. So patients with psychotic disorders such as schizophrenia or schizoaffective disorder, or sometimes bipolar disorder. And then patients who need travel coordination from outside the Lower Mainland. So that's not as applicable, obviously, here in Vancouver or on the North Shore, but patients who might be coming in from Northern British Columbia or Sunshine Coast, et cetera. And then, as I mentioned, everybody else who isn't deemed to be urgent priority or high priority falls into the routine booking category and is given a next regular booking bed. And so this is patients who's deemed to need an inpatient withdrawal management admission, but is not deemed to be high or urgent priority. And most of our patients with stimulant use disorder do end up falling into this category, but I'll talk about some of the caveats for booking for stimulant use disorder shortly. As I mentioned previously, when I showed the graph of the how our wait times have been affected by implementation of this overhaul, the routine category is the one that's been the most effective, because we were still relatively good at identifying priority and getting patients into beds previously, but we've certainly trying to optimize that on an ongoing basis. So before implementation of our triage framework in 2023, the routine bed wait time was 8 to 10 weeks, which, as you can imagine, is quite impractical. A patient might call today in the middle of June and they might be booked for detox in August. And, a lot of things can change in 2 months, as well as patients, may be experiencing significant risk related to their withdrawal of their substance use during that time. So with implementation of this framework, our current state as of this week is about a routine wait time of about 4 to 7 days, which, as you can see, is not much longer than our urgent wait time and our high priority wait time, which are 1 and 3 days. So I wanted to talk about other factors that we do take into consideration. So these are things that can help contextualize a patient's triage. Every case is individual. Their assessment is individualized, and obviously people do not fit into each of these categories perfectly. It's not black and white, and so there's a lot of factors and a lot of context that needs to be considered. So other factors that might be at hand when categorizing or triaging can include some of the following, but are certainly not limited to this list. So that's Indigenous patients, patients that identify as LGBTQ, patients who have no fixed address or deemed to have unsafe housing, geriatric patients over the age of 65, or patients who are fleeing domestic violence. I wanted to sort of make note of the no fixed address caveat is that, again, we are not comparing, when we're triaging, we're not comparing towards the general population. We're comparing to the list of other patients who are on the detox wait list. And as you can imagine, there are many patients, unfortunately, that are unhoused that are on the wait list for detox. So having unstable housing or having no fixed address in and of itself doesn't necessarily end up prioritizing someone, because unfortunately a lot of our patients are under that circumstance, but it's something that might be taken into context along with other risk factors that are identified. Something we also try to do is coordinate detox admissions with intake dates that line up with bed-based or treatment recovery. So for example, if a patient has an upcoming admission to like a residential treatment program, they need detox before that treatment program, we want to try to coordinate the timeline of those admissions so that the patient can seamlessly transition from one phase to the next. So I also want to highlight some other general considerations. One of which is stimulant use disorder. So currently, in order for a patient to qualify for an inpatient withdrawal management bed booking for stimulant use disorder, they need to meet two general criteria. So one is severe stimulant use disorder based on the DSM-5 criteria, and the second is daily or near daily stimulant use. As I mentioned, these patients are usually booked for a routine bed, but they can be triaged higher into the urgent or the high category of other priority factors are identified. The most common that would typically apply in this case might be decompensation of a patient's primary mental health condition. So if they do have a psychosis and their stimulant use is deemed to be exacerbating that, or is resulting in unsafe situations for themselves or others, or maybe it's contributing to incarcerations, or it's contributing to hospital visits or hospital admissions, and those things might be taken into consideration. Another common one might be if a patient has a primary stimulant use disorder, but they are having unintentional opioid overdoses from inadvertent fentanyl exposure in the crystal meth supply, for example, and that patient would be prioritized because that is obviously a morbidity and mortality risk associated with their stimulant use. Next, I'll talk about patients that have opioid use disorder who are declining opiate agonist therapy. So previously, patients were able to book detox to undergo opioid tapers that was not paired or not linked to opiate agonist therapy, so a hydromorphone taper or morphine taper, for example. We no longer permit patients to be admitted for this purpose, just because we know there's good evidence that there is a significantly increased risk of both overdose and death after discharge from contained facilities such as detox, hospital, incarceration, etc., without pairing OAT. So we try to have this discussion with patients when their bed is booked to say, okay, you have opioid use disorder, you're hoping to come to detox to get on OAT. Which one are you hoping to get on? Are you on one right now? Has something worked for you in the past? Just to identify that, the patient has that goal in mind. And if they're not currently on OAT and they don't want to start it over the phone that day with the addiction medicine Access Central physician, then they're made aware that if they arrive at detox and they are declining OAT once they're admitted, that they may be discharged just due to these safety concerns. The last thing I wanted to highlight is patient catchment. So Vancouver Coastal Health detox beds are funded for Vancouver Coastal Health residents. So the intention is that patients are booked within their home health authority. So patients, for example, who live in Fraser Health should not be booked to Vancouver Coastal Health detox beds. They should be booked to the Fraser Health Authority detox beds. Certainly, we do make some exceptions for patients that are transiently located. So maybe a patient who's living with no fixed address in Vancouver Coastal Health, and maybe traditionally they were previously a Fraser Health patient, but now are living no fixed address in VCH, or patients who are receiving ongoing care from care teams in VCH, or maybe are attached to specialist teams in Vancouver Coastal Health, or who are arrived for an acute care assessment at a VCH hospital, then sometimes these exceptions are made to be practical and patient-centered. So next, I'm going to go over the Access Central Physician Consult line. So this is a direct line available to hospital-based and rapid access addiction clinic-based addiction medicine physicians and nurse specialists to request detox triage for patients with whom they've already completed an in-person addiction medicine assessment that day. And the intention of this is that the patient doesn't have to undergo a duplicate specialist assessment, because if they were to pick up the phone, call the centralized intake number, they would have this specialist nursing assessment done on the phone. But if an addiction medicine physician or an addiction medicine nurse has already completed that fulsome assessment, then there's no need to duplicate that for the patient. It's obviously not very patient-centered or efficient. So currently all Vancouver Coastal Health-based hospitals that have an addiction medicine consult team, the consult team would have access to using this phone line. And then our three Vancouver Coastal Health Rapid Access Addiction Clinic-based services. So that's the Safe Paws Hospital RAC, the Downtown Eastside Connections Clinic, and the Lighthouse Virtual Substance Use Clinic. Next, we're going to talk about Access Central complex case rounds, more so that you can just be aware of what it is in case one of the patients you care for is a complex case rounds patient. You'll just have a better understanding of what that is and why the patient falls under that purview. So these were implemented in February of last year to review bed booking and care planning for patients who are frequently accessing withdrawal management services or who are considered to be outliers in terms of their booking frequency. The goal is not only to review these high utilization clients, but to ensure that bookings are being put into a place thoughtfully, appropriately, or to optimize their booking strategies. So currently, any patients with 7 bookings in the last 12 months, whether they've shown up for that booking or not, are automatically brought forward for this review. But other patients with complex cases or complex needs may also be reviewed even if they don't meet this threshold. We hold the rounds every Tuesday, and then patients who are awaiting a complex case rounds review are typically not offered a bed booking until their review has been completed. And this so these are multidisciplinary rounds. They involve Access Central physicians, nurses, social workers, and then depending on the patient that we're reviewing, we often invite the patient's community care teams to come attend their rounds review. So that might be an outreach worker, sometimes their physician, their psychiatrist, their case manager, their counselor, et cetera, just to help provide a different additional context to the patient scenario so that the correct care plan can be developed for them. Access Central currently documents in Profile EMR. This is where the vast majority of documentation occurs. It's mostly done in real time or at the very latest same day. And then confirmed bed bookings are often cross-posted to Cerner if the patient is accessing a BCH-based hospital. Access Central may also reach out directly to some community clinics or teams for collateral information or notifications regarding bed booking or planning. So this is an important slide to highlight for primary care providers as it pertains to Access Central. So obviously I told you about the Access Central physician consult line, but we do not currently, unfortunately, have capacity to take calls directly from community care providers such as primary care physicians who are not addiction medicine specialists. However, that being said, you can still help advocate for your patient to get a detox bed, and I'm going to walk you through how that would look and how you might be able to go, access that for your patient. So the best thing to do is have the patient call the Access Central main line with you while they are physically in your clinic. Um, the Access Central nurse will undergo the addiction medicine specialist nurse assessment with the patient on speakerphone while the representative from their clinic, be it their physician, the nurse, their social worker, case manager, et cetera, is on the line. And that way they can hear the assessment, ensure its accuracy, provide additional contextual details that might help allocate the patient's triage for detox. So this can be any member of the care team, but depending on the patient's individual case, if there's medical complexity, then sometimes the primary care provider is the person best set up to contextualize the medical details. And if necessary, if the case is complex, the Access Central nurse might then run the case by the Access Central physician to complete the triage, which is part of our routine process at Access Central. So these are things you might be asked as a primary care provider or a care team member if you're calling on the line with a patient from Access Central. So they might ask you to help identify any priority factors for detox, or if you already know of any and can offer them, that really helps. Obviously, we're gathering a lot of information from a patient and from their chart very quickly over the phone. So anything that can be highlighted or mentioned up front helps sort of speed up the process. Identifying any medical or psychiatric complexities that might arise is also helpful because sometimes patients are and their chart may not reflect like the real situation. Also confirming there's no other potential barriers, so like any issues with ADLs, mobility limitations, complex wound care that might have arisen, any violence or aggression history that you're aware of. And then other relevant case information such as past medical history, medications, if they've recently been undergoing medication titrations related to their substance use disorder, providing some additional context or information around that can be helpful. If the patient's trying to rotate different types of medications related to their substance use, that, providing sort of an overview of that can also be helpful. And then depending on what category your patient is triaged into, if your patient is urgent or deemed to be urgent, that doesn't necessarily mean that a same day bed is available. So you may be asked kind of, if we don't have a bed today, what would be your backup plan? So are you planning to send the patient to the emergency department? Are they appropriate to go home and come back in the morning to discuss bed booking the next day, that sort of thing? So that's the end of the formal part of the presentation. We'll now move into answering any questions. As Liz mentioned, there's a QR code for you on the screen to complete your evaluation component of the presentation. And then Liz will let me know if she wants me to stop sharing my slides versus keep them open to answer any of the questions if they're